Good morning. The subcommittee will come to order. Thank you for joining us today for the oversight hearing, VA Accountability, Actions Taken in Response to Subcommittee Oversight. Almost 1 year ago today, during my first hearing as chairman of the Subcommittee on Health, we met to discuss the persistent lack of productivity and staffing standards for specialty care services at Department of Veteran Affairs medical facilities. We learned that VA had yet to implement such standards despite more than 30 years of reports and recommendations directing the department to do so. I was so alarmed by VA's decades-long lack of action that I quickly introduced H.R. 2072, the Demanding Accountability for Veterans Act. H.R. 2072 would require VA to ensure that Inspector General recommendations concerning a public health or patient safety issue were addressed, identify those within the VA medical facilities who are responsible for implementing needed changes, and prohibit the VA from awarding a bonus or performance award to any employee who does not fully address a recommendation under his or her purview. The goal of this legislation is to create a culture of accountability within the VA, a culture where problems are identified and immediately corrected, and leaders are held responsible for their actions. Were H.R. 2072 in place 30 years ago, VA would have been required long before now to implement productivity and staffing standards for all specialty care services, and who knows how the health and well-being of the veterans seeking care through VA would have improved as a result. I wish I could say that the first hearing was the only time that we have seen evidence of a lack of timely action taken by VA in response to serious problems. Unfortunately, that is not true. Since the conclusion of that hearing, we have held other hearings and roundtables on topics ranging from the care provided to veterans with chronic pain and who have experienced military sexual trauma to concerns regarding department-wide procurement reform and third-party collections. At each of these oversight forums, we have heard example after example of VA failing to act swiftly to address important issues or respond to the subcommittee's request for information in a timely manner. I'm a surgeon. When a serious problem is identified, my instinct is to act without delay, to cut out what needs cutting out, and to fix what needs fixing. While I understand that large-scale changes often happen slowly, especially where large government bureaucracies like the VA are concerned, I think we can all agree that our veterans deserve more than what we have seen in the last year. I'm hopeful that H.R. 2072 will be heard on the House floor in the coming weeks, where I'm not content to wait for what can often be a lengthy process to ensure that the VA is on track to address the many issues the subcommittee has identified through last year's oversight efforts. So during today's hearing, we will assess the progress, if any, that VA has made in response to the subcommittee's hearings and roundtables, determine whether appropriate steps have been taken to ensure accountability when and where deficiencies in care have been highlighted, and identify what further actions may be necessary to improve the care and services provided to our veterans. Though the topics we address today are wide-ranging, they are undoubtedly interconnected. If we do not ensure that the department is on track to implement appropriate productivity and staffing standards, then we cannot be sure that we have the right staff in place to care for veterans experiencing chronic pain. Similarly, if we do not ensure that the VA is taking necessary actions to improve the collection, where appropriate, of third-party revenue, then we cannot be sure that we are collecting every available dollar that could then in turn be used to improve the care and services provided to veteran survivors of military sexual trauma. Last week, I had the privilege of conducting an oversight visit to the West LA VA Medical Center. During my conversations with the clinicians and support staff there, each of the issues we will discuss today were brought up by the providers when I asked them what needed to be improved in order to make it easier for them to care for our veterans. I cannot state enough how critical it is for VA to take responsibility for gaps in care, and more importantly, to take immediate and definitive steps to address them. Unfortunately, I have seen little concrete evidence in the past year that the department is doing either. Concurring with IG and GAO reports is simply not enough. Sending out guidelines without accountability is not enough. I sincerely hope that today's conversation will change my mind. With that, I will recognize Ranking Member Brownlee for any opening statement she may have.
Thank you, Mr. Chairman, and good morning. Today's hearing is intended to follow up on various oversight hearings and roundtables held during the first session of the 113th Congress and to assess the progress that the Department has made in addressing these critical issues. The subcommittee will also determine whether appropriate steps have been taken by the VA to ensure accountability and identify what further actions may be necessary in response to subcommittee oversight. Last session, this subcommittee held oversight hearings on physicians' staffing standards, care and treatment for military sexual trauma survivors, and VA's overuse of prescription painkillers to treat veterans with chronic pain. In addition to the oversight hearings, 2 roundtables were held, one focusing on procurement reform and access to care, and one on billing and collecting from third-party health insurance companies for non-service connected care. There were many issues raised during these hearings and roundtables. Issues such as developing a plan to establish productivity standards for all specialty care services within 3 years, decreasing the amount of time it takes to procure large medical equipment through the National Acquisition Center, assessing the department's programs for veterans who have experienced military sexual trauma, and ensuring the effective use of opioid therapy for patients with chronic pain. Mr. Chairman, these are but a few of the concerns that were brought up during testimony and conversations we had with the witnesses and participants during these forums. While we have a lot of ground to cover today, I am especially interested in hearing from the VA on improvements made in the military sexual trauma program and in procurement reform. At the MST hearing held last session, we heard firsthand the experiences of veterans who have found the system unfriendly and intimidating. According to the VA, fiscal year 2013 saw an increase of 9.3% in rates of engagement of military sexual trauma related care at VHA. Additionally, the VA reports an increase of 14.6% in military sexual trauma-related visits in fiscal year 2013. I would like to hear from the VA how they are addressing these increases. I am sure we all agree that it is critical that Congress do all that we can to make it easier for victims of military sexual trauma to access needed benefits and services and receive treatment. Compassion and care are a significant part of healing those that have been sexually assaulted. Turning now to procurement reform, Mr. Chairman, last session we held a roundtable, and during that roundtable discussion we heard about the long delays, some for up to 2 years, in the delivery of medical equipment. While I understand that VA is streamlining the procurement process to decrease the amount of time it takes to procure large medical equipment through the National Acquisition Center, I do not feel confident that much progress has been made in that area. Stakeholders continue to report increased difficulties accessing needed prosthetic equipment through VA and significant delays in contract awards at the National Acquisition Center. I find this very frustrating and unnecessary. I hope the VA has good news on this front today. Mr. Chairman, thank you for holding this hearing today, and I want to thank everyone in attendance. There is obvious concern for veterans and VA's ability to meet their health care needs. Thank you, Mr. Chairman, and I yield back the balance of my time.
Thank you, Ms. Brownlee. With that, I'll introduce our first and only witness panel. Representing the department is the Honorable Undersecretary for Health, Dr. Robert Petzel. Dr. Petzel is accompanied by Dr. Jesse, the Principal Deputy Undersecretary for Health, Dr. Agarwal, the Deputy Undersecretary for Health for Policy and Services, Dr. Jane, the Assistant Deputy Undersecretary for Patient Care Services, and Mr. Philip Matkowski, the Assistant Deputy Undersecretary for Health for Administrative Operations. Together, each of you represent the lead VA witnesses at the 3 oversight hearings and the 2 roundtable discussions that will be the focus of today's hearing. So thank you all for being here today. Dr. Petzel, please proceed with your testimony.
Good morning, Chairman Jack and Ranking Member and members of the committee. Thank you for the opportunity to discuss the progress that we've made regarding Veterans Health Administration's physician staffing, productivity standards, treatment for veterans who experience military sexual trauma, pain management, and procurement reform. The chairman has already mentioned the people that are accompanying me. Veterans Health Administration is the largest integrated healthcare delivery system in the country, providing 85 million total health care appointments, and last year we had 25 million consultation requests. And we deliver this care at 1,700 VA healthcare sites. I want to address first the issue of accountability. Allegations of misconduct by employees are taken seriously by VA. When we learn credible allegations of misconduct, VA addresses them immediately. When incidents occur, we identify, mitigate, and prevent additional risks. Prompt reviews prevent similar events in the future and hold those responsible accountable. If an employee misconduct or failure to meet performance standards is identified, VA does take appropriate action. Effectively treating veterans who experience military sexual trauma continues to be a top priority for VA. We are committed to ensuring that appropriate MST services are available to meet the treatment needs of both men and women. Since last year's hearing on military sexual trauma, VA has taken a number of steps that have resulted in improvements. VA is in the process of administrating and implementing an enhanced universal MST screening to include a clinical reminder for referrals. We're providing military sexual trauma telemedicine health for rural veterans. And recently we distributed to all affected employees an information bulletin on managing military sexual trauma. A number of roundtables were hosted to examine the impact of department-wide acquisition reform. Since that roundtable discussion, the department has expanded its use of authorities to acquire care from community health care providers, successfully launching the Patient-Centered in the Community, or PC3 effort. VA has completed its consolidation of billing through the Consolidated Patient Account Centers. And additionally, we have welcomed the oversight from the Health Subcommittee during our roundtables. We've used this oversight process to inform continued improvements in our administrative processes, which we'll illuminate during the hearing. Last year, we also participated in a hearing regarding VA productivity and staffing. Today, I'm pleased to report that by the end of March 2014, we will have productivity and staffing standards in place for 25 different specialties, representing 81% of our total physician workforce. And we're on target to deliver productivity and staffing standards for all VA physicians by the end of fiscal year 2014. In October of 2013, VA briefed the OIG on its progress. Based on VA's briefing, the OIG has closed out all of its recommendations related to physician staffing. The work continues and will not be finished until all physician specialty productivity and staffing standards are complete, implemented, readily accessible high-quality, efficient specialty care is available to all of our nation's veterans. Lastly, VA is providing comprehensive pain management services to improve the health of veterans. As an update to last year's pain management hearing, VA recently developed and implemented an opioid safety initiative program to ensure opioid medications are used safely, effectively, and judiciously. The program is already bringing positive results. The basis for this program is to make visible the totality of opioid use at all levels, patient, provider, and facility, in order to identify high-risk situations. To support a system-wide approach, VA disseminated guidance and tools to help providers to communicate long-term opioid therapy expectations to the staff and to their patients. In addition, a multi-module, team-based step care model has been implemented throughout VA. Every VA medical center has a pain clinic and a consultation service for pain, an opioid monitoring and provider feedback program, and the capacity to provide interdisciplinary treatments such as physical therapy, behavioral therapy, non-opioid medications, and alternative medical care such as acupuncture and meditation. VA prescribers also have the ability to participate in the state prescription drug monitoring program to determine if a patient of theirs is receiving controlled substance prescriptions from non-VA sources. Mr. Chairman, the Department of Veterans Affairs is committed to providing the highest quality of care that our veterans have earned and that they deserve. As mentioned earlier, important progress has been made regarding these programs. We at VA will continue to identify, mitigate, and prevent vulnerabilities within our healthcare system wherever we find them. VA will continue to ensure accountability, and when adverse events do occur, we will learn from them, improve our system to prevent these incidents from happening again. This concludes my testimony. I appreciate the subcommittee's continued interest in the health and the welfare of America's veterans, and at this time, my colleagues and I are prepared to answer your questions.
Thank you, Dr. Petzel. I appreciate your response. I expect we'll have multiple rounds of questions today, and I'll begin by yielding myself 5 minutes. And while the purpose of this hearing is to go over the issues that we raised over the past year in the hearings and subcommittees that we've done, I just want to ask a few questions about your statement. Specifically, you said allegations of misconduct by employees are taken seriously. When we learn of credible allegations of misconduct, the VA addresses them immediately. So within the past year, the committee has examined disturbing lapses of leadership, including several incidents around the VA, like at the Pittsburgh VA Medical Center, where the several veterans succumbed to Legionnaire's disease. There was apparently some improper emergency room care that led to 3 preventable patient deaths at the Memphis VA, according to the VA Inspector General's report. And recently, 19 preventable deaths were reported nationwide, including 6 deaths at the Columbia, South Carolina VAMC, and 3 deaths at the Augusta, Georgia VAMC due to avoidable delays in care. So, were these incidents I just reported to you, were they considered credible allegations of misconduct?
Yes, Mr. Chairman, they were.
So then, what specific actions were taken immediately upon your being aware of these?
Let's go back and go through each one of them individually. At Memphis, 2 physicians have been disciplined. 1 has been removed as a result of the actions in Memphis. At Columbia, 3 senior executives have resigned under threat of discipline. And at Pittsburgh, as you may remember, there was a criminal investigation done by our criminal IG and by the Department of Justice. When they finished, they found that there was no criminal activity. In fact, they found that only 1 of those 6 patients had actually died from Legionella, and the others died from other illnesses. At any rate, we were forbidden from doing any further investigation or taking any action until after those investigations were finished. They finished, and we're now in the process of evaluating disciplinary action for people at Pittsburgh.
There was some other reference to mismanagement not linked to deaths, or discipline described as temporary written warnings. tell me more about that. I mean, it seems sort of an inadequate mismanagement not linked to deaths. What's the appropriate action for that type of behavior?
That's in my mind, a hypothetical question. It depends on what has happened. The range of discipline that can be occurred is anywhere from an admonishment to removal. I would point out that last year VA removed 3,000 employees, approximately 1% of its workforce. They, over the last 2 years, have either removed or seen resignations on threat of discipline from 14 senior executives, and an additional number of senior executives on probationary periods were fired during their probationary period. So, we do discipline our workforce. We do hold our workforce accountable.
Well, it's amazing when I keep hearing this, but to define specific instances seem to me to be a little bit more difficult. I'm happy to be able to hear what you had to say about those particular cases, but it seems that from my experience that finding the person responsible, it seems to be difficult, as we talked about in the the physician staffing hearings that we had.
Let me just make just a couple more comments, if I could, Mr. Chairman. We've got a pretty extensive oversight system that includes the activities of this committee, the special counsel, the Office of the Inspector General, the GAO, and the Office of the Medical Inspector. These all help us determine whether or not people were accountable for the action. The IG investigated Pittsburgh, as an example, and did not find that there was any individual that they felt was culpable.
My best example of that, to tell you the truth, Dr. Petzel, is the example of when we had the physician staffing hearing, and the IG over the last 30 years has 8 times said that there should be a centralized plan for physician staffing, and yet that centralized plan over the last 30 years doesn't exist. And when I asked the fellow testifying, he said, well, we'll have a plan in 3 years. And yet I couldn't find out the name of the person who was supposed to respond to that Inspector General report and make that plan happen. I mean, the IG said you need a central plan. You agreed with them 8 times over 30 years, and yet it didn't happen. So, and we couldn't find out who the person who was supposed to be doing that is. So that, this is the frustration that I have as the chairman. And, I'm over time now, but maybe we'll get back to that, but I'd like to yield to Ms. Brownlee for her 5 minutes.
Well, thank you, Mr. Chair. I certainly want your question answered, and I wanted to just kind of follow up as well on the productivity standards for specialty physicians too. And if I heard you correctly, Dr. Petzel, you said that all will be done by the March 2014?
That's correct, Congressman Brownlee.
Okay, so all of them will be done by 2014. So then I have to assume that all of the various milestones in both stage 1 and stage 2, as was laid out by you to me, have all been completed then at this particular point in time.
I'd ask Dr. Agarwal to comment on it.
So, Ranking Member Brownlee, you're correct. We had stated in our testimony at that hearing that we will complete all specialty physician standards within 3 years. However, we have accelerated that path, and at this point, as Dr. Petzel mentioned, we have completed the standards for 81% of our specialties, and we intend to complete all of them this fiscal year. So, yes, ma'am.
Can you give me an idea of what the outstanding ones are?
Of those specialties?
Yes.
Yes, ma'am. I do have a list with me. If you would like me to go through, I'd be happy to do so.
Well, if you could just give me a few off the top of your head just to have an idea of what they may be.
The ones that are remaining?
Correct.
Okay. So we have for thoracic surgery, vascular surgery, cardiology, surgery, anesthesia, emergency medicine, pathology, amongst a few that we still need to complete. The ones that we have already completed are as follows. When I had initially testified, we had the staffing models for primary care. as well as radiology, and mental health was on its way. And I'm pleased to say that the Director for Mental Health staffing went out a couple of months later after the hearing. Subsequently, the standards that we have placed are for dermatology, gastroenterology, neurology, ophthalmology, orthopedic surgery, urology, as well as allergy, immunology, endocrine, and I have the list with me. So I'll be happy to share that with you.
Thank you very much. And I just, again, as a follow-up question, that once all of these are established, then can you explain to me how we will then measure sort of the accuracy and the effectiveness of these standards for all of the specialties that you've developed? So are you creating metrics for us to measure the effectiveness and the quality responses?
I'll let Dr. Agarwal give you some details about that, but just it's sort of an overview. The staffing standards look at the delivery of services within a department, say cardiology or ophthalmology, and they also blend with that the access that we have to those services. So they look at the access standards, and we get a picture of the productivity of our staffing and the effect that it's having on the ability of people to access the care, which I think is the ultimate thing that we're looking for. We want to have enough people to provide good access, not so many people that we're not being effective in the way we administer that program. And Dr. Agarwal, you might add anything to that?
Sure. So subsequent to the hearing, ma'am, we've gone ahead and we've developed many tools that will assist the local facilities in managing the specialty resources appropriately. We would like all our specialists to work at the top of their license, which entails that they also need to have the necessary support staff so that they are able to perform their specialist duties in helping veterans. And to that end, I will reference back to the tool that Dr. Petzel just mentioned. It's an algorithm that links access with specialty productivity. This has been trained, all our leadership has been trained to use this tool in how they manage the specialty resources in the clinics. And I'm sorry.
Yeah, I think what I'm trying to drive at, and I think it's important for you as the experts to be able to evaluate the effectiveness and the quality of delivery of services. What kind of tools will Congress have, will the veteran community have to also be able to measure the quality and effectiveness of these specialties?
That's an excellent point, ma'am. So this tool has been currently distributed to all our facilities, and they are using it to manage the resources within their medical centers. So the ultimate outcome of this is going to be better access of specialty services to the veterans, as well as our ability to use our specialists most efficiently and effectively. To that end, I do not know. We would like to share that information with Congress as and when you would like to have it. We can do that periodically at your request.
Thank you, and Mr. Chair, I yield back. Exceeded my time.
Thank you, Ms. Brownlee. I'd like to yield 5 minutes to Mr. Helskamp.
Thank you, Mr. Chairman. I appreciate the opportunity to follow up on some issues we've discussed in the last year. I appreciate your line of questioning, and hopefully you'll take that up when you return to that. But one thing I'd like to first ask the VA is in reference to a year ago, approximately a year ago, during a March 6th hearing, I asked the GAO some questions regarding the scheduling practices at the VA. During the course of my questioning, the GAO noted the dates were changed to game the system at several clinics. And I believe, Mr. McCoskey, you were in attendance at the hearing, and I asked your colleague, Mr. Schoenhard, what was being done to prevent this from happening again, and whether any penalties were imposed on the employees caught doing this. My question for the VA is this: who has been held accountable for these actions?
Before I turn to Mr. Metkovsky, Congressman Helskamp, let me answer that. The GAO was referring to a system that we used for scheduling that we have since abandoned, which had in it the possibilities of both misunderstanding of what might be scheduled and of what the times might mean. We have moved to having the fundamental scheduling criteria be what we call the create date. And that create date is not fungible. That's the date that the individual calls into the medical center or wherever it might be and asks for an appointment. That becomes then the starting point for measuring whether or not we have accomplished seeing that patient within the 14-day criteria that we've set out. So that shouldn't occur. I can't speak to what has happened previously.
Well, Doctor, so you've abandoned the system that allowed and permitted employees to falsify and game the system. My question is, have you held anybody accountable for the actions that were identified by the GAO?
I would have to go back, sir, and look to see if there were any disciplinary actions in those 3,000 that I mentioned that were specifically related to that issue. I don't know the answer to that question here.
Any of the other conferees, can you answer that question, whether anybody was held accountable for gaming the system?
I can't answer the question directly because there are 70-some thousand people who have scheduling keys in our system, so I don't know specifically whom you're referring. I think the important point is
did you follow up with the GAO? They had evidence of that. They had identified specific instances.
I can't give you the specifics on that.
No one here followed up on the GAO? And you saw this report yesterday suggesting that's going on elsewhere in the system, in which the VA purged thousands of medical tests. This is just yesterday's article to game its backlog stats. So first question, follow up with the GAO report, it was just ignored then?
No, Congressman Heelskamp, I went back and asked some of our team to identify, if we could, the allegations that were presented by the GAO during that hearing. We were not able to find concrete evidence that the GAO had, and they did not actually give us the specifics so that we could go to the individual and find it. So we did follow up. We could not find the concrete evidence to engage an appropriate disciplinary action.
So you just abandoned the system and those employees that were followed. A little more on the GAO. So the GAO made allegations, and you never reported back to the committee that I'm aware of that the GAO was mistaken or provided no evidence of that. That seems, I've appreciated the product from the GAO, and you're saying here they had no evidence of that.
That is not what I'm saying. I'm saying that we did not have independent evidence outside of the GAO report that could identify an individual who engaged in the
practice. Well, where did they come up with that, sir?
They had their evidence.
Their evidence is from your system.
That's correct, sir.
So their evidence was inaccurate?
It was interview-based, if you recall. So they had a series of clinics that they visited, and then they went through and monitored the behavior. They measured that behavior against the policy, and they identified that someone, instead of selecting the desired date of the veteran, were asking the veteran when they wanted to be seen and using that as the desired date. So they were monitoring behavior specifically, and we were attempting to find evidence of that in our own, and we could not.
And lastly, any responses to this report, again, of gaming the system that came out yesterday? Apparently, a request for documents describing when the practice began or how many appointments have been canceled was refused.
That was almost what I would call a scurrilous newspaper report. Several years ago, the West LA, Greater Los Angeles healthcare system embarked on a very carefully thought out review of past requests for consultation or x-rays in the imaging department to see if indeed there were requests that had not yet been closed out. They identified 300 requests that had not been closed out. They had not been closed out because the patients had moved, because the patients had failed to show up for the appointment or repeat appointments. There was nobody who needed the care that was denied the care. There was no attempt to eliminate a backlog by destroying records. You can't destroy the records. They're electronic, and they're there forever.
But they were administratively closed, is that?
They were administratively closed.
And according to the article, it's not a few thousand, it's 40,000 in LA and 13,000 in Dallas. And I appreciate, one last thing, it does say in the article, and like a follow-up on each of these, Ms. Chairman, I might, says performance reviews and bonuses of top hospital administrators are linked to meeting those goals. So I would like to see if there's a connection like that as indicated in the article. I yield back, Mr. Chairman.
Thank you, Mr. Hillscamp. Ms. Negrete McLeod. Dr. Ruiz.
Thank you for being here. Thank you for your service, and thank you for all your hard work. We definitely have to continue your efforts. There's a lot of problems that we need to fix, and I appreciate that we're moving in the right direction, albeit perhaps impatiently slow, but we have to continue to move in that direction. You know, Mr. Mitkovsky, I wrote a letter to you dated February 6th about procuring 3 ultrasound machines for my regional VA hospital. They have been waiting for a long time to get 3 simple ultrasound machines. When I was in Haiti after the disaster as the medical director for the largest internally displaced camp in Port-au-Prince, with about 60,000 Haitians living under sheets and sticks in the midst of our Western Hemisphere's most severe disaster, we needed ultrasound machines. And I made a phone call to a local hospital in my area. 2 weeks later, we get an ultrasound machine. And you talk about logistical nightmares, you talk about bureaucracy, you talk about the difficulty in transporting ultrasound and getting the right one, etc., to an earthquake-stricken country. Why does it take so long to get those ultrasounds? 2, when can we get those ultrasounds?
Thank you, Congressman Ruiz. That letter is actually being responded to by Mr. Fry. He's our senior procurement executive as well. I think it was co-addressed. If I may just address a little bit of the consolidation process that we've historically used in VA. We have a national acquisition center that has all of our national contracts for what we call high-cost medical equipment, the high-cost high-tech, ultrasound, MRI, CT scans, etc., are all acquired through that central service. And what we've typically done historically is we consolidate our purchases. We did that under the premise that through consolidation we would achieve better price competition and then achieve some measure of return. We've looked at that process in 2012. At the end of 2012, our consolidation was 909 pieces of equipment. These ultrasound machines were part of that consolidated purchase. We expect to finish all of the delivery orders for those by April of this year. So in answer to your question, the delivery orders, if they have not been issued, will be issued by April. Now, we're looking at that process and figuring out how we can do it a little bit faster and a little bit different.
Can I ask a question there? You said delivery orders. My goal is the end goal, the actual outcome. So tell me the time it takes between delivery order and then actually the Loma Linda VA receiving the ultrasound.
So I do not have an answer for that. That would depend on the manufacturer that gets the ultimate delivery order, but it can be as quick as 3 months or less depending upon the manufacturer. We ran a separate process. Let me just, I can see your expression, sir. So we ran a separate process as a result of our roundtable, which Chairman Benishek and Ranking Member Brownlee held. And we carved out some different cost items, portable x-rays, C-arms, and we ran those at the network level in VISN 15, which is in the heartland of the country, Missouri. And those that we purchased through that process from the beginning of the requirement through the actual contract award was 90 days, right? As compared to 400 or so days for a consolidated process. That equipment began arriving, the portable x-rays began arriving before the end of calendar year 2013. Start to finish, less than 6 months. Not exactly the same as your Haiti example, but considerably faster. We're going to try that again in Network 23, just to make sure we can iron out some of the kinks, and we're going to use that process system-wide from here on out once we finalize just a couple of details. We hope that's going to speed it up a lot, and then we're also going to look at the consolidation process and change that as well.
Thank you very much. I'm going to continue to follow the natural life history of requesting 3 ultrasound machines until they are born in the womb of a Loma Linda VA hospital. So, thank you so much, and I'll follow up with you.
How long has it been that this is
It's,
going?
how long is it? It's been 2 years, my friend. 2 years for 3 ultrasound machines.
All right.
That's too long, I agree.
Thanks for that. 5 minutes for Dr. Wenstrup.
Thank you, Mr. Chairman. I appreciate you all being here today. And forgive my ignorance on my first question, but I'm curious if any of you have ever, as doctors, been in private practice where you ran your own business. Have any of you been in private practice?
I have not. I've worked in academic medicine, but not private practice.
Okay. Because this is where I draw the line on so many things. For example, if the VA hospitals and their providers operated under Medicare rates, for example, or even say 105% of Medicare rates, and providers were paid fee for service, do you think the VA hospitals would be in the black?
Yes, personally I do. We've done several studies going back as many as 10 years and looked at our cost of providing a service as opposed to the private sector cost of providing service, or compared to the Medicare reimbursement. And in virtually every instance, we're talking 15 to 25% less cost associated with providing that service. So yes, I think we could survive very well on Medicare rates, very well.
Because there's a part of it sometimes that makes me curious as to what motivates the VA system, the way it's funded, et cetera, to really be effective and efficient compared to, say, private practice. Because I've operated under both systems. And besides personal pride in the work that I do, and besides motivated to try and see as many patients as I possibly can effectively, those are personal things, but what within the system motivates that? For example, because I found, and I'll use DOD as an example, as a reservist. In private practice, in the time that I would see 45 patients effectively and efficiently in my private practice, because of the way military hospitals are set up and the physician staffing, et cetera, I could only see 15. I mean, that's just a fact. And I've offered to you in the past to come into the VAs and work with you on the staffing issues, and I've not heard anything from anybody on that. And I've mentioned it to Secretary Shinseki as well. But so what within the system motivates, stimulates the entire system to be extremely effective and efficient? What does that?
Thank you, Congressman. That's an excellent question. First of all, it's the mission. I mean, we are taking care of people who have earned and deserve the care that we're delivering. The second thing is that we have an unlimited demand on the service with a limited budget. We don't generate more money if we do more work. We get our budget at the beginning of the year, and we have to take all comers because of that. That has driven tremendous efficiencies in this system. Tremendous efficiencies. We grow by 1 to 1.5% in terms of the number of people we treat every year. Our models for funding have in them productivity standards which say that we have to increase our productivity by 1 to 2% every year. That's a tremendous, tremendous motivator. I would match our efficiency and our cost of doing business against the private sector at any time.
Okay. When in the effort that you're making with providing appropriate staffing, in our private practices, are we increasing our staffing so that we can treat patients more effectively, increase access, things like that, as well as have good outcomes? There's a real number value to that. So are you doing a follow-up on that will show, yes, we are now seeing more patients at less cost and being efficient, and will we have access to those types of numbers?
I'd have Dr. Agarwal to comment on that.
This is an excellent question, sir, and that's exactly what we recently asked. Since we have provided these tools to our local managers and managing these resources as to how it is that they're using it to make the clinics much more efficient and ensure that all the specialists are working at the top of their license. And the information that we've gotten back is actually been very good. Looking at the resources that they are providing to the clinics and what is the output, what is the value that they are achieving, I think has made possible for certain changes would not have been so prior to that. So to be able to tell a specialist that you need to spend more time in the clinic or taking care of certain groups of patients has been possible because now when the access data and the productivity is sort of aligned and it's sort of placed in a way that people can understand much better, it gives you insight into whether additional resources are needed or not, or enough resources have already been provided, but some other changes need to be made. So we believe that in the longer run, once this becomes the way how we practice, especially with the resource management part, this is going to be extremely beneficial.
Well, yeah, I think it can be. I mean, assuming you're going to see everyone eventually that needs care,
Right.
we actually have a tremendous savings if we see them sooner and do it more efficiently and effective. So if you want to make sure that when you add a staffer, it's because you get a better result,
Exactly.
better outcomes.
Exactly.
So I think that's what we want to hear back from you on over time as this is implemented. Thank you, and I yield back.
I just want to comment for a moment. Dr. Petzel, that answer you just gave Dr. Wenstrup, that's just completely ridiculous.
I'm sorry.
That answer that you gave Mr. Wenstrup, and that you think that the VA is as efficient as the private sector, that's, I worked at the VA. All right, in order to get the number of cases that I had done in the private sector and the VA, it took me like a year to get the staff up to speed so I could do the same amount of cases at the VA that I could do in the private sector. I mean, motivating the staff at a VA hospital to get things moving and to use your time effectively is a tremendous, tremendous problem. And that answer that you gave that said that would put you up against the private sector any time, that is a complete fabrication of what actually occurs at the VA. I mean, I worked at the VA for 20 years, okay? So I know that that's just not true. And that, having people from the outside who have been in the private sector, whose time is valuable, who are sitting in the doctor's lounge doing nothing for a half a day, while, a turnover time of a half an hour, which is done in like 7 minutes in the private sector, is very frustrating to physicians. And, that kind of answer isn't going to wash it here. So with that, I'm going to give Ms. Kuster an opportunity to ask a question. Thank you.
Thank you very much, Chair Beneček. I appreciate it. And thank you to Vice Chair Brownlee for your leadership on these issues. I have two questions, if I could. One has to do with a company in my district in New Hampshire, Salem, New Hampshire. The company is named Gamma Medica, and they make a medical device that produces bone density imaging to help with early detection of breast cancer. And my question is not specifically about them, but my understanding is in New England, many of our VA health facilities have requested this life-saving device, but due to over 2-year-long delays, many veterans seeking early breast cancer detection are not receiving the treatment that they, delays at the NAC. And my question, this is to Dr. Petzel, can you tell me how the VA is actively engaged with improving delays for new technology at local facilities? And what steps have you taken since the roundtable last April on procurement wait times that we had to work with NAC on improving the amount of time it takes to deliver life-saving devices?
I would defer in a moment to Mr. Metkowski, who has gone through that, but just to say that we are not happy with the 2-year process as well. The bundling, from my personal perspective, puts delays on this acquisition that I think are unnecessary. There's a compromise here between trying to save money by bundling and on the one hand, and on the other hand, delaying the acquisitions because we're bundling. But Mr. Metkowski, why don't you just go through again, what you had said about what we're trying to do to reduce that time.
Yes, sir.
Thank you, and I apologize that I had to come in late.
No, that's okay. Congresswoman Kuster, the one thing I would state is that in our efforts to establish a structure that was more economical, we left out a critical variable in history, which was speed. Our supply chain should also focus on speed. Procurement reform should establish compliant, economical acquisitions, but they should also be fast. Following our roundtable, we did review how we do the consolidations. We're trying to change those. It's going to take us a little bit of time. The big focus was the end of fiscal year 2012 orders that went in. There were 900 of those. The bone densitometers for Gamma Medica may be in that consolidated process, but it's not a process that is working in terms of speeding the new technology for application. What we're trying to do now is move the less complex items so that they can be purchased at our 21 network offices through their contracting officers. In a sense, instantaneously, you have 21 additional work teams now focusing on it rather than just the one up in Chicago. We wanted to make sure we could test it. We found out that there were some clauses that were competitive with our national contracts. We're going to extend the test a little bit more, and then beginning in fiscal 15, that'll become the way of business. That'll free up these national acquisitions to be a little bit faster as well. By April of this year, we expect to be finished with all of the delivery orders from that last major consolidation. Then it'll still take some time for the technology to be in medical center.
Okay, thank you very much. My other question has to do with an issue that many of us have been involved with in the past year on military sexual assault treatment. I've been visiting the VAs in White River Junction and in Manchester, and have actually been quite impressed by the protocols there, but I'm not familiar across the country. We had a hearing last July where we had some very compelling testimony from veterans, and we were talking about whether veterans are being adequately screened for military sexual trauma. I think if I recall the testimony, they were only asked on the initial visit and they weren't asked on subsequent visits. So I'd like to hear how the VA is following up with the local VA health facilities to measure the effectiveness of screenings and follow-ups, and also how are you providing local, smaller VA facilities the information and tools they need to train and educate providers to treat survivors of MST?
Dr. Jane was at that hearing, as you remember, and I would ask him to comment on the changes and improvements we've made since then.
Great, thank you.
Thank you, Congresswoman Kuster, for that question. So as you mentioned, this was a fairly compelling testimony that we heard last year. So we've taken several steps. First of all, the entire screening has now been revised, so the questions are being revised. We believe that the questions were not very clear before, so we added a little more clarity. We've also added an option where the veteran could decline to answer the question, so they could answer the question whenever they felt they were ready and to whom they felt comfortable with answering the question. So if the veteran were to decline to answer the question, then within the year, the reminder would kick back in and the question would be asked again, so we don't lose that opportunity.
Oh, that sounds good. Instead of people assuming that that's a no answer. Yes, ma'am. It's a decline answer, and then you would revisit it.
We will revisit that. We will also have added a functionality where a third question has been now added. Through the pilot, we learned that the veterans want to be referred to mental health or to specialty care, and now we'll be able to track those referrals, and we'll be able to follow up through our data and numbers to see how the individual facilities are doing with following up on the reminders.
That sounds great. And I don't know if this would be possible to add to your protocol, but I just want you all to be aware, and maybe there's a way it could be factored in. We were successful in passing a bill to provide whistleblower protection to members of the military who come forward with claims of sexual assault, men and women. And I think it's an important piece of information because of the history on this issue, and because of the retribution and retaliation in some cases in people's careers, that there was good reason not to come forward. And so I'm hoping that you will find a way to incorporate this to reassure victims who come forward that, that this whistleblower protection will be in place.
We could certainly look into that, Congresswoman, and see how we could incorporate that.
Thank you. Thank you very much. Thank you, Mr. Chair.
Yeah. I'm going to go start another round of questions, and I got a couple things. Dr. Petzel, would you provide the committee, for the record, the circumstances surrounding the 14 SES employees you said the VA forced to step down in the past 2 years? We'd like to have that by the end of the week if we could.
Clarify that, sir. I had the numbers wrong. There were 14 serious disciplinary actions taken. 6 SES were dismissed over the last 2 fiscal years, 3 non-probationary, and 3 first-year probationary, and we will provide whatever information you want related to that.
All right, thank you. I'm going to go back to one of the hearings that we did in the past to follow up. It's concerning the care and treatment of military sexual trauma, and I think Dr. Jane was the primary witness at that. And I just want to follow up a bit more. I mean, you said we're going to take a critical look at how we structured services and what we can do to address some of the gaps. And you also said, I think there are many points that the veteran witnesses made in terms of suggestion that we would take to heart, and we will go back and review our current policies and procedures. So, Dr. Jane, what specific actions have you taken to improve the situation? You mentioned the questioning or the asking about sexual trauma, but what else specifically have you done to address the concerns that we brought up in that hearing and that were brought forth by that testimony?
Thank you, Mr. Chairman, for that question. So as I was just stating to Congresswoman Kuster, so the first big thing we did is to do a careful analysis of our screening process. And as I was indicating earlier...
You went through that, but go
yes, sir.
through something else.
So that was number one. Secondly, we've also looked at our outreach activities that we're doing. So we have modified our outreach posters where the male and the female survivors are included in the posters. We're also doing outreach with Department of Defense. So at the time of transition, this is an activity we have taken in the last few months. So as the service members transition from DoD to the VA, the information regarding MST services is now provided to them, so they know and they understand what services will be available to them in the veteran status. So that's an improvement. We've also taken education and training activities. So we've trained the MST coordinators on the sensitivity relating to the male survivor issue that was presented at the hearing. We want to make sure that our male survivors can receive cares in a gender-sensitive manner in our outpatient clinics, so they don't have to go to a women's clinic, for example, to receive services. We've also made sure that
that change has occurred, then you're saying?
Yes, sir. That training has already occurred. We've also trained the VISN leads that provide the MST services to monitor that activity. As you know, we also make site visits. And so we're tracking this as part of the site visits to make sure the facilities are providing the care in a gender-sensitive manner. And then we are also doing a mystery shopper type sort of activity where both the male and the female staff members would randomly call the VA facilities to speak to a MST coordinator to just understand how long will it take them to reach an MST coordinator, whether they are able to address the questions in a sensitive manner. So these are all the changes that...
How's that working out?
That is actually going quite well. We've been very pleased with the training and how that's taken hold.
Well, I'd like to see a report on what
yes, sir, we can certainly...
that's a great idea, I think, having somebody just call in anonymously and figure out what's actually happening. So if I could get a report on that, I would like to see that.
We'll
how many times you called, the response, all that. Well, I appreciate your answer there. I think I'll yield to Ms. Brownlee. I want to keep the questions coming. Thank you.
Thank you, Mr. Chair. I wanted to also follow up on the military sexual trauma issue as well. You talked about the outreach that you're doing, and thanks to the chairman, we had a hearing in my district last week talking about mental health services, but a component of that discussion was about outreach, and one of the problems that was discovered in the various testimony is that the West LA facility was doing the outreach for mental health services for the Ventura County, and Ventura County wasn't providing the outreach, and it was clear that the West LA facility was not aware of all of the programs that were accessible to veterans in the county. So their outreach is basically ineffective because they have no idea about all of the nonprofits and volunteer organizations and so forth that could help our veterans. So when you talk about outreach for the for our victims or survivors, I should say, of military sexual trauma, what does that outreach really look like? And I know that the IG had recommended and thought it would be very, very beneficial to have a central sort of program resource list that would be, at every VA medical clinic or every community-based outpatient clinic, across the country. So if you could respond to that, please.
So thank you, Ranking Member Brownlee. I think there are a couple of things that we have done, so I may not have a complete answer for you, but part of the outreach, as I mentioned earlier, is with our Department of Defense colleagues. But the other part of work that we have done is reached out to OEF, OIF counselors within our own system. As you know, within the VA, majority of the outreach work in the communities is done by our OEF, OIF counselors. So our MST team has now trained the OEF, OIF counselors to begin to do the kind of outreach that you're referring to so that we can reach out into the community with nonprofits and also with other types of resources that are out there. So I can't honestly say to you that it is completely functioning, but this is part of the process that we're now beginning to go beyond just the DoD into the community.
Thank you. And I also wanted to get a clarification in the testimony. Dr. Petzel's testimony indicated that the VA established a benchmark of 0.2 full-time equivalent employees per 100 veterans who screened positive for MST. So help me to understand what that means. Is that the equivalent of a full FTE per 500 veterans affected by MST?
So thank you, Ranking Member Brownlee, for that question. So the process, the way it works, is that in our Office of Productivity and Efficiency, we have created a tool that monitors the numbers of MST survivors that we're treating and the staff resources that are dedicated to treat those MST survivors. So from that tool, what we have determined is that it takes, on an average, 2 staff per 1,000 or 0.2 per 100. The staff would include all of the mental health staff, not just a particular staff member. So those facilities, so the last report that we have available is for FY12. For FY12, 99% of the facilities met that staffing standard. There was only one facility that fell off. So after the hearing, we immediately got after that particular facility, developed an action plan, and since then they have made the corrections. The FY13 report would be available within the next few weeks, and we'll be able to see how the facilities are doing to these staffing standards.
Okay. Well, we would certainly like to see that report. It's hard for me to comprehend, honestly, that when we have a veteran who is in dire need and who is experiencing very, very deep trauma, that a 0.2 FTE is adequate. And I know you said that's from a variety of services, but kind of culled together, it equates to a 0.2 FTE, correct?
So let me clarify again, Congresswoman. This is at a larger data trend issue, but for that individual veteran, we will provide them whatever their services they need through our mental health clinic. Now, what we emphasized right after the hearing, as you recall, some of our witnesses were very concerned that when the VA was not able to provide the care in a timely manner, that we did not refer them to a non-VA care. So we continue to emphasize to our staff that non-VA care is a available option. And I think, as Dr. Petzl said, PC3 and availability of PC3 that would happen starting April and beyond will make it easier to reach out to community providers. So for individual veterans, the 0.2 issue does not apply. This is for monitoring purposes, that we keep track of what staffing resources are being dedicated to provide the services.
So if that's the benchmark of which you're going to measure, then it's hard to measure that a veteran who, again, is in deep trauma in the moment that they need our help, if they've gotten all of the resources, because your measurement's going to be, a 0.2, sort of a kind of a across the board in the aggregate. So, I'm not sure that that's a good metric. Maybe I need to understand the metric in further detail, but I think we are all most interested, in obviously the screening part that you've talked about, but when we have a veteran who has gone through this kind of trauma and needs our help in that moment, it takes a lot of attention and a lot of support, so it doesn't translate for me.
Just if I could respond a little bit to that, Congressman Brownlee. The metric looks at the system overall, that 0.2. We would be evaluating the effectiveness of caring for individual patients through a variety of different ways. I'm not familiar exactly with what we do in military sexual trauma, but as an example with depression, they would take a survey beforehand, they would take a survey after 1 year that they've been treated to look at their score on a depression scale. Those are the kinds of things.
A survey which is to ask veterans how the VA responded to their needs.
Or how do they feel?
Right.
The Beck Depression Scale measures your level of depression. I'm just using that as an example. That's the kind of thing that we would use to measure the effectiveness of what we're doing, not this metric of, this is just a gross way to say the facility appears to be devoting in the aggregate the resources needed. But you're absolutely right. We need to look.
But the report may I just have one more second? But the report that you're saying was in 2012 and we're going to get in 2013 as a measurement based on this metric.
Correct.
Not a survey of veterans who are survivors of military sexual trauma and how the VA responded to them.
Correct.
That data we will not get.
Not in that 2013 report, but Dr. Jane and I will talk about what we can do to provide you with information about the effect of what we're doing.
I yield back, Mr. Chair. Thank you.
Thank you. Mr. Hillscamp?
Thank you, Mr. Chairman. If I might, I'd like to follow up on a few of your questions and drill down on some of the accountability issues with employees at these preventable deaths, which have, I guess, been confirmed by the VA to committee staff. But in the Columbia, South Carolina Center, which were 6 preventable deaths, were there any employees held accountable for those preventable deaths?
Well, first of all, the concept of preventable deaths, I think, requires some discussion, not here. Yes, there were. There were 3 employees at senior levels who resigned under threat of discipline.
But they were not disciplined. They left before the discipline.
They left before they could be disciplined, correct.
So perhaps, and I guess we're arguing about whether the preventable deaths, they were allowed to resign and move on.
Allowed to resign. It is their right to retire or resign.
There's no way to hold them accountable when people die because of their failures?
If somebody wishes to retire or resign, we cannot prevent that from happening.
There is no way, no criminal investigation, nothing along that lines to hold these former VA employees accountable?
There was no criminal charges or intent involved in any of these situations.
And then the 3 deaths at the Augusta, Georgia Center, I don't know if you answered that. Was anyone held accountable for those 3 preventable deaths?
Yeah, we had a similar situation where a number of people have either retired or resigned.
And Mr. President, I would hope you could provide that information to the committee within 30 days. The other one that I didn't see was the VA Pittsburgh system with Legionnaires, and we had a hearing, and it was just a shocking hearing to me. I guess it's arguable in your mind how many veterans died as a result of that, but you did indicate at least one actually died, Legionella. Was any VA employee held accountable for the failures that led to this death?
As I said earlier, Congressman Hulskamp, we are in the process of evaluating the disciplinary action to be taken to Pittsburgh. It was delayed because of the criminal investigation, which didn't allow us to do anything.
So you had criminal investigation there, but you didn't pursue that. No one pursued that at Columbia, where there were 6 preventable deaths.
The IG pursued a criminal investigation. There was no indication, nobody raised the question of whether there was a criminal intent at any of these other facilities.
The preventable death, at least the one that you confirmed here, when did that occur at the Pittsburgh VA Center?
One moment, sir. July 12th, 2012.
How quickly do you expect the criminal investigation is complete or not, and when will you move to some accountability act?
Criminal investigation by the criminal IG is complete. They found no criminal activity or intent, and I'm hoping that very quickly we will have the evaluation of disciplinary action at Pittsburgh concluded, and we'll know what we're going to do.
Okay, I look forward to that report. And lastly, at the Atlanta VA Medical Center, the Inspector General linked 3 preventable patient deaths to widespread mismanagement. Yet we heard that the medical center director maintained no employees responsible for the mismanagement linked to the deaths should be fired. Is that still the case?
Well, first of all, the IG did not link any deaths to the activity at Atlanta. There were 3 mental health deaths, but the IG made no comment in their report on the quality of care that was delivered to them or the course of action. And 7 people at Atlanta have been disciplined in various ways as a result of that activity.
The IG's report, I thought, linked that to mismanagement issues. You were saying it did not, but you disciplined someone anyway?
Specifically, the IG said that there had been mismanagement of the contract for contract mental health services, and there had been mismanagement on the mental health ward. They did not link any deaths to those activities.
But you do say 7 employees have received some type of disciplinary action. Last we'd heard in the fall it was 3 employees received temporary written warnings. Can you describe the 7 or the actions of the 7 employees that were held accountable?
I don't have the specifics of what happened with the 7, but we certainly can provide that generically to you.
Well, I would like it, rather than generic, I would like it answered, obviously.
Well, we can't name the individuals, but we can tell you exactly what was done.
Oh, absolutely. But again, last fall, this committee was told there was temporary written warnings for 3 individuals. And so I'd like clarification. Apparently, you've done some more since then.
There were at the time of the previous hearing, there were 3 actions that actually had been taken, and there were 4 actions pending. All have been now taken.
Okay, I look forward to that report. Thank you, Mr. Chairman.
Thank you, Mr. Hulskamp. Dr. Wenstrup.
Thank you, Mr. Chairman. I appreciate all of your level of expertise and your medical backgrounds, but to be honest, I'm a little surprised that there's not people involved with administration that have been in the private sector. I think it would be extremely helpful. And I didn't come to Congress to sit here and complain about things, but to try and bring solutions. And that's the drive of my efforts here. Well, let me ask you, Dr. Agarwal, a question on, for example, in an 8-hour day in the VA system, on average, how many patients would an orthopedic surgeon see?
Sir, that would be hard for me to sort of say. If it's an outpatient clinic, I would assume that.
I'm talking about in the outpatient clinic setting, assuming their surgery day is different. We can get to that later, but just in an 8-hour day in the outpatient clinic, doing their post-ops, et cetera, how many patients do they see on average? And if you don't know, that's okay.
I actually do not know.
Okay. See, this is the type of thing I'm talking about when I'm talking about measuring productivity. And you say you've been doing this, and we've talked about it for last year, and you don't have an idea. So what are you measuring? Because I was operations chair for 26 doctor orthopedic group. These are the things we looked at. And how do we improve our staffing so that we can be more productive and still provide the care? And our reputations are on the line with this too, so it's important. So I'd like to know what type of metrics you're going to use, and that goes back to my previous question before. And I'm not trying to be a pain, but are you going to do something that's effective and efficient? And if you don't know those numbers, then you don't even have a baseline to start with. That being said, let me go back to where Dr. Benishek weighed in, having his experience at a VA, and your comments, Dr. Petzel. I'm just curious to know if a VA hospital budget was based on the previous year's activities, submissions at a Medicare rate and fee-for-service. If that was your budget based on your previous year's productivity, based on Medicare rates, you say that yes, you would be in the black. So it'd be interesting to know if that actually would cost the taxpayers more or less, if that's how your budget was based. And based on your comments, it almost sounds like that would come in less than what we actually budget for you. And so would you be comfortable exploring that notion?
Certainly.
Thank you. And I yield back.
Thanks, Dr. Winstrup. I have another question, and I'm just trying to cover the issues that we covered over the last year, and one of them is the third-party billing issue that we had talked about, and perhaps Mr. Matkowski can answer this. Can you tell us about what's happening since you gave us the testimony there? Are you collecting better? Have you changed anything since I talked to you last? I've got a couple of follow-ups too.
Yes, sir. We covered 2 topics there. One of them was non-VA medical care, and if you want, I can give you a little update on where we are with the patient.
Well, let's start with the collections, yes, because that's what we're here for.
And then for collections, as a result of that roundtable discussion, we had a public request for information, which is a precedent to a request for proposals, to look at are there industry systems that would allow us to automate the billing process a little bit better. When we analyze the turnaround time for billing, we notice that one of the longest times that it takes us is actually from the outpatient event, the inpatient event, to the generation of the bill. And a lot of that is because of the manual process. So we had a competitive RFI, request for information, and we're evaluating those responses. We're also working with our IT organization to determine whether or not the systems enhancements would be considered IT and subject to that funding, or whether we could use them under administrative funding.
Okay. Well, I think that gives me an idea where
Yes,
you're
sir.
at. The only other question, as far as like the getting out, I know you talk about this PC3 thing, and you kind of led me to believe that this is going to help solve the problem of getting outside the VA services to our veterans in a more timely fashion. But my concern, frankly, is 2 things. The reimbursement rate that providers are going to be provided through the VA, and like sort of what's the take from the insurance people, what percentage of the total spending is going to be made to get these third-party networks on board? Can you tell me about that?
Sure. First, I would tell you that we kicked it off in January on time. There was a little bit of a delay, but it's now running. It's in 47 of the initial 50 medical centers are referring patients through to the PC3 networks. There are somewhere north of 5,000 referrals that have been made to the network. I will tell you that our agreement, however, is with the intermediaries, not with the firms themselves. So we have an agreement with TriWest, we have an agreement with HealthNet corporations, not with their provider networks. However, both contractors are required by their contract to have a built-out network for us. So the incentive for them is to have as competitive a network as they can for us to provide them referrals. And that's actually by the basis of the contract as well.
The question I asked was the reimbursement to the providers, what level is that going to be at? And at what percentage of the total money that you're spending on TriWest or wherever it is, what percentage of the total spending is going to go to their management fees and which is going to go to actual provider care? Do you understand?
Yes, I do, sir. So
Can you answer that question, or is it not available?
First of all, our agreement is with TriWest and HealthNet, not with their subcontractors. Second of all, though, the structure of the contract is that we pay at a CMS rate to TriWest and HealthNet, and then they'll have a rate somewhere below that, but we're not privy to that. There is an administrative fee, which is separate to the direct clinical fee, which TriWest and HealthNet would also bill us, and we expect that their administrative charges would be captured there and not to the detriment of their network. There are incentive structures in the contract as well, so based on the ability of those organizations to build out their networks, they get an incentive payment as well.
So there's a separate administration fee?
Yes, sir.
And then there's a payment that you're saying is sort of Medicare rates to the providers, or
Yes, sir.
That's to TRICARE, and they're going to pay the providers less than that then? Is that what you said?
We do not have privy of information about their agreements to their providers.
Well, I'm just trying to be sure that the system actually is able to procure providers, because if somebody's offering, a very low rate of reimbursement, you're not going to get very many people
So far,
to sign up.
So far, sir, we're seeing it not to be the case, that we are actively starting up the sites where we are. In Vision 23, it is up and running. There are a number of referrals. We are not seeing the inability to build out our networks at this point.
All right.
Thank you, Mr. Chair, and I will promise you I'll watch my time. I wanted to go back to the one question that I didn't think got answered. Maybe it did, but I didn't hear it, about the IG's recommendation for establishing a central program resource list for MST-related programs. Is that something the VA is going to do or believes that it is also beneficial?
I'm not sure, Congressman Brownlee, about the question. I'm not aware of any central program list in the OIG recommendation that's outstanding that I know of. The only one that we know of that is outstanding is the whole issue of travel and Benny travel issue. That was the only one that we were aware of. The only other thing that it does occur to me, so there was one issue in OIG, yes, I do recall, and that was the issue that within the VA's intranet, there is the availability of different programs and who are the MST coordinators. And we have addressed that concern, and we've updated that list, make sure that the staff is aware that when they need to refer a patient to a larger VA, for example, for MST-related services, who is the contact person, who they need to contact. That has been updated and has been addressed.
Okay. Thank you very much. And then I just wanted to go to the issue of chronic pain, and I'm wondering about in testimony before, we've had testimony with the Tampa Chronic Pain Rehabilitation Program, and sort of what are we learning, best practices, lessons learned there.
Congressman Brownlee, let me make a couple of comments, and I'm going to turn it over to Dr. Jesse, who was at that hearing. The VA has developed what I think is probably the most robust pain management program for a large integrated delivery system in the country. The the Tampa inpatient program for pain management is an example of the kinds of services that we have to offer. We have taken very seriously the problem with opioid management and pain. I think the physicians in this room will remember that 15 years ago, it's felt that pain was undermanaged and pain medications were pushed. You need to get rid of the pain. That has obviously led, and I'm not talking about the VA, I'm talking about medicine in general, led to a problem in this country of the overuse of opioids in managing pain. And the VA, I think, is very seriously addressing that problem. Dr. Jesse?
Thank you. So there are some very long and detailed explanation I can give. I think the VA has a very good story to tell, but if coming back specifically to Tampa, Tampa is an inpatient rehabilitation facility that's unlike almost anything else you can get. That a patient get this without paying out of pocket is unheard of in this country. It's a CARF accredited program. In 2000, we had, I think, one CARF accredited program. We now have 10. We have 14 in process of that accreditation process. With our goal is to ensure that every VIS and every network has at least one. And that's part of the overall strategy that Dr. Petzel referenced of a stepwise pain management program, beginning with a very comprehensive base in primary care, including the ability to use therapies other than pharmacologic. You heard about acupuncture, about meditation, imaging therapy, behavioral therapy, and the like, and escalating the ability to have consultation from pain experts, and escalating up to the higher level pain centers where, in fact, we can use much more technical programs like spinal stimulation, which was discussed at the last hearing, like nerve blocks, injections, thermal nerve ablations, and frankly, the kind of very intensive inpatient rehabilitation programs that Tampa offered.
So you believe that that is moving really across the country in terms of looking at all of the alternative therapies that you just suggested?
Yes, absolutely. So we have as part of the strategy not just the opioid safety initiative, which is key, but it's also the ability to use other strategies to relieve pain rather than just masking them. That's not the right way to say that, but rather than just using pharmacological therapy. So for instance, as part of the joint program with the Department of Defense, there is a program called ATAX, I think is the acronym. I don't remember exactly what it stands for, but it's to train acupuncturists in what's called battlefield acupuncture, auricular acupuncture. Relatively effective at managing pain. The goal, we presently have, I think, just shy of 20 trainers. The goal is to have 400, and rolling that program out. Developing that capacity is key. And frankly, the whole goal of VA, as we've discussed in the past, is to provide personalized patient-driven care, which really includes a wholesale embracement of, I think, what the industry would call integrative care, integrative medicine, and that's and that's part of our fundamental plan of healthcare delivery in VA.
Thank you. I'll yield.
Thank you, Ms. Brownlee. Dr. Jesse, I also want to ask a couple questions on that,
Sure.
On our pain hearing that we had. And I just want to hear this specifically. I mean, you give some, generalized answer here, but specifically since our hearing, what have you done to educate the physicians within the VA about pain management? What is it? Has anything changed since our hearing last year? What have you done?
Well, so if I may, clearly things have changed because since the hearing last year, there are 20-some thousand fewer veterans on opioids. we have been rolling out these initiatives not since the hearing, but literally since, for 4 to 5 years. They take time to get in place. They take time to build the infrastructure. The opioid safety initiative began to be rolled out prior to that hearing, and since the hearing, there's been a significant acceleration of that. The pilots at Minneapolis, for instance, there's been over 50% reduction in the use of opioids. There is it's called JPEP. It's the Joint Pain Education Program that's run jointly with the Department of Defense, because as we've discussed in the past, one of the key issues, and this came up in the past hearing, if you remember, is that we don't want a lapse between somebody who is being treated on the military side and coming over to the VA. And part of that is to ensure that we actually have the same approaches to managing pain across that spectrum of the delivery systems, the military system and into the VA system. So that program's being rolled out. As I mentioned, the acupuncture training program is ramping up. So yes, there are a number of issues that are in play that have been much more accelerated since that past hearing. We have the PDCI, the post-deployment health, has calls that average about 400 calls, 400 people on those monthly calls. We have another set of specific pain management calls that have been averaging around 300 in the past several months. It's moving up to close to 400 primary care providers mostly engaging in these calls. So I think the answer is yes. There is concrete and accelerated activity in these areas.
Well, I thank you for that answer. I don't want to be overcritical. I mean, we just went to the West LA Medical Center and met with a couple of their pain specialist providers, and the system they had in place there, at least the way they explained it to me, it sounded like it was actually pretty effective with alternative modalities being incorporated and having the pain specialist involved in the case at a certain level, and they had pretty good criteria. And so I don't mean to say that everything's bad, but the purpose of today was for me to kind of get a follow-up on what is happening, because I hate to have these hearings where we bring up these issues and then nothing else gets done, or I don't know the follow-up being done. So I truly appreciate you all being here today for me to try to get some more information. I understand Dr. Wenthrop has a follow-up question he'd like to ask.
Thank you, Mr. Chairman. Actually, sort of on that subject, do you know what percentage of the VA hospitals are participating in the prescription drug monitoring programs in cooperation with the states?
That's a very good question, Congressman. Everybody is querying. That is, our providers are asking the state about their patients. As near as we know, that's happening across the country. The reporting of our activity is an IT issue. We have 6 pilots in places like Kentucky and Tennessee, which have been very successful. And the process is in place now to roll this out to the rest of the country. The limitation is IT, is getting the right people to, it's complex. You've got different reporting phenomena in each state, and you've got 152 medical centers, and getting that stuff married up IT-wise is taking us some time.
Is there anything we can do?
Dare I say it? IT money? IT is our lifeblood. Everything anymore that we do in medicine has an IT component to it, one way or the other. But I think that the money is in place to do this. The people are in place to do it. It's just a matter of getting it done.
Do you have a timeline? You think we have a pretty big problem in my district with prescription drug abuse. It's been cracked down in Ohio.
In Ohio.
Yeah, and it's been cracked down a lot. We've closed down a lot of the pill mills. That's all been done at a local level within the state, but it's still an existing problem. Plus, we border other states, so sometimes we've got it within Ohio, but not necessarily in the other states. And having the VA information would be helpful as well.
It is, and I'd like to take for the record the question of how long, and we will get back to you. quickly about exactly what the timeline is. Just a little bit about that. It's very important from our perspective to know the prescriptions that are going on the outside.
Right.
Are people, doctor shopping? Are they using other people? And it's important for the states to know what we're doing,
right,
so they can put that in, make that information available to the private sector. So this is very important.
It's helpful both ways. There's no
Yes,
doubt about it.
absolutely.
Thank you, and I yield back.
Well, I think that concludes the questions that I have today. I do have to ask before we adjourn that we do have some further written questions we'd like to have submitted for the record. I suspect that you guys hopefully will get those answers to us. There's a lot of lengthy stuff there that I would like to get some follow-up for, but we don't need to have it here today.
Yes,
so I appreciate you all being here. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and to include extraneous materials. Without objection, so ordered. And hearing is now adjourned.